So here, we're gonna talk about the different abnormal cells found in the blood. First is the stomatocytes or the mouth cells. These cells are elongated RBCs with a slit-like central pallor or RBCs with irregularly speculated surfaces. Conditions associated are hereditary acanthocytosis or a beta-lipoproteinemia or the macleoid syndrome. Next is the echinocyte. Echinocytes are RBCs with regularly speculated surface. It is usually round at the tip. Conditions associated are usually caused by artifactual dyeing of smear, bile acid abnormalities, or due to the effects of barbiturates or salicylates. But there is another one, the Burr cell. The Burr cell are RBCs with regularly speculated surface. They are more pointed at the tip. Conditions associated are the uremia, acute blood loss, cancer of the stomach, pyruvate kinase deficiency. Next is the ovalocyte. Ovalocyte are oval-shaped RBCs. Condition associated with this is the hereditary elliptocytosis. The cryocytes or teardrop cell. These cells are pear-shaped or teardrop-shaped RBCs. Conditions associated are PMF or the primary myelofibrosis, previously known as myelofibrosis with myeloid metaplasia, pernicious anemia, thalassemia, and some hemolytic anemia. Next is the schistocyte. Schistocytes are fragmented RBCs. Conditions associated are patients with artificial heart valves, microangiopathic hemolytic anemia, uremia, severe burns, and DIC or disseminated intravascular coagulations. DIC, overactivation of coagulations and fibrinolytic system. Conditions associated are snake bites, obstetric complications, sepsis or the excessive infection, and acute promyelocytic leukemia or AML3. Next is the drepanocyte or sickle cell. Sickle cell has two forms. Irreversible sickle cell RBCs are crescent-shaped with long projections. When deoxygenated, they tend to fragment. And the second one is the oat-shaped cell RBC with less pronounced projections. When deoxygenated, they return to normal shape. Sickle cell or crescent-shaped RBCs. Conditions associated with this are sickle cell anemia and hemoglobin sickle cell disease of the period. These cells are a result of losing a large portion of a cell perimeter, taking on a bite-like appearance. It is usually seen in drug-induced hemolysis. Next is the elliptocytes. Elliptocytes are more ovalocytes. These cells are cigar-shaped RBC or bipolar or central distribution of hemoglobin. Conditions associated are sickle cell anemia. Pappenheimer bodies or the siderotic granules. It is the intra-erythrocytic collections of iron. Conditions associated are sideroblastic anemias and hemochromatosis or hemosidrosis. In right stain, it appears as dark staining dots. Howell-Jolly bodies. These are frequently appear singly in a cell, only one per cell, usually round and less than 1 micrometer in diameter. Frequently appear singly in a cell,
in the hematopoiesis, you have now knowledge on how cells are produced. And it is important to stay on track about this topic I'm going to discuss, which is anemia. Let's have an overview about anemia. If you have anemia, your blood does not carry enough oxygen to the rest of your body. The most common cause of anemia is not having enough iron. Your body needs iron to make hemoglobin. Hemoglobin is an iron-rich protein that gives the red color to the blood. It carries oxygen from the lungs to the rest of your body. Anemia has three main causes: blood loss, lack of red blood cell production, and high rates of red blood cell destruction. Conditions that may lead to anemia includes heavy periods, pregnancy, ulcers, colon polyps or colon cancer inherited disorders, a diet that does not have enough iron, folic acid or vitamin B12. Blood disorders such as sickle cell anemia and thalassemia or cancer, which will be discussed later on in this video. This is an overview when you are dealing with anemia. And what we'll do later on is divide each categories of different types of anemia. For example, under microcytic anemia, which we'll take on first. First and foremost, we pay attention to MCV being less than 80 cubic micrometer. And under microcytic anemia, it includes iron deficiency, anemia of chronic disease, thalassemia alpha and beta, and sideroblastic anemia. Under macrocytic, we'll divide it into megaloblastic and non-megaloblastic, and that become really important to us. For example, the megaloblastic here that are often tested are folic deficiency, vitamin B12, or cobalamin deficiency. When we say megaloblastic, it is always macrocytic, but not all macrocytic are megaloblastic, because there are also non-megaloblastic anemia. With fatigue and tiredness, right, that's all. And then you will take the proper patient's history, and then you'll figure out and we'll make this setting up the organization pattern, divide into hemolytic and non-hemolytic. So I will take the category here, and these are all non-hemolytic. For the most form, for example, you have a patient with parvovirus 19, reflects you're taking aplastic anemia, correct? And maybe your patient is taking chloramphenicol and is receiving chemotherapy. Maybe the kidneys got damaged, whereas all I have is common. I would take the category here. And these are all non-hemolytic. For the most form, for example, you have a patient with parvovirus 19, reflects you're taking aplastic anemia, correct? And maybe your patient is taking chloramphenicol and is receiving chemotherapy. Kidneys got damaged, no erythropoietin, no erythropoiesis. Next, chemotherapy, bone marrow shutdowns, suppression of bone marrow function, no bone marrow function. So parvovirus B19, it hits bone marrow. What happens? Aplastic. If you are never able to properly form your RBC from the bone marrow, how can you possibly destroy them? You cannot. Good, the spleen. And we walk through all of these in detail. So all of these in some point are end up at the spleen, or maybe perhaps intravascular. But guaranteed, there was destruction of the RBC because there was no problem in bone marrow, hence we call it hemolytic anemia. So now let's talk about the different common types of anemia. First in the list is the iron deficiency anemia, or also known as IDA. It is the most common form of anemia in the United States. prevalent in infants and children, pregnancy, excessive menstrual flow, elderly with poor diet, malabsorption syndrome, chronic blood loss because of the gastrointestinal blood loss due to hookworm infection. IDA's etiology. Okay, when we say etiology, it is the manner of causation of disease or condition. These are inadequate intake of iron, increased need because of growth or pregnancy, impaired absorption because of celiac disease, and chronic blood loss because of the hemorrhage. So how will we diagnose IDA? First, the laboratory diagnosis, the screening studies for CBC and iron and micro and hypoanemia. Second is the clinical manifestations like fatigue, dizziness, pica, stomatitis, glossitis or sore tongue, koilonchias or spooning of the nails. Next to IDA is the anemia of chronic inflammation or disease. It is due to inability to use iron for hemoglobin production. Anemia of chronic inflammation is originally called anemia of chronic disease. An acute phase reactant called hepcidin is a mass of regulatory hormone of systemic iron metabolism. In cases of inflammation, there is an increased iron supply to macrophage and hepatocytes, a decrease of iron in enterocytes, decreased iron supply to bone marrow for production, and an increase in ferritin. Where ferritin binds more iron, which renders developing RBC deficient of iron since they don't have ferritin receptors. Sideroblastic anemia. While in anemia of chronic inflammation, there is inability to use the iron for hemoglobin production. Here, we have an adequate iron supply, but the problem is the protoporphyrin production, which causes anemia. This protoporphyrin is important in forming iron complexes. This protoporphyrin is important in forming iron complexes. The excess iron accumulates in the mitochondrial region of the mature erythrocytes in circulation. The hallmark of sideroblastic anemia is the ring sideroblast. There are two types of sideroblastic anemia: the primary and the secondary. The primary is irreversible cause of Black's anode, while the secondary is reversible. Causes include alcohol, anti-tuberculosis drugs, and chloramphenicol. Next classification is aplastic anemia. Aplastic anemia most commonly affects people around the age of 50 and above. It can also occur in children. Patients who have poor prognosis with complications that involve bleeding, infection, and iron overload due to frequent transfusion needs. It can be genetic or acquired. Genetic aplastic anemia or Fanconi anemia is an autosomal recessive trait and is strongly associated with malignancy development, especially acute lymphoblastic leukemia, dwarfism, renal diseases, and mental retardation might be seen. Acquired aplastic anemia, on the other hand, is caused by antibiotics like chloramphenicol and sulfonamides, chemicals like benzene and herbicides, viruses like B19, parvovirus, secondary to measles, hepatitis, CMV, and Epstein-Barr virus. Is the myelocystic anemia or the marrow replacement anemia. It is a hypoproliferative anemia caused by the replacement of bone marrow hematopoietic stem cells by malignant cells associated with cancers, the lungs, breast, and prostate cancers with bone metastases. Blood loss anemia. Acute blood loss anemia and the chronic blood loss. Acute blood loss anemia is characterized by sudden loss of blood resulting from trauma or other severe forms of injury. Some clinical symptoms are hypovolemia, rapid pulse, while in chronic blood loss anemia, it is characterized by the gradual, long-term loss of blood, often caused by gastrointestinal bleeding.